Hi and welcome back. We frequently encounter ST segment elevation in ECG, but not every ST elevation is myocardial infarction. In this video, let us discuss the various differentials of ST elevation in an ECG. Of course, number one is acute ST elevation myocardial infarction. So here we have ST segment elevation and Q wave formation in at least two contiguous leads with reciprocal ST depression in the electrically opposite leads. We'll see more about this STEMI ECG in our next video. The second differential is acute pericarditis. In acute pericarditis, we see widespread concave or saddleback ST segment elevation with PR segment depression in multiple leads, with the reciprocal ST segment depression and PR elevation in leads AVR and B1. The third differential is Prince-Metal angina because of coronary vasospasm. Here, the pattern of ST elevation is similar to acute STEMI, that is localized ST elevation with reciprocal changes. But unlike acute STEMI, the ECG changes here are transient, reversible with vasodilators. Fourth differential is ventricular aneurysm. So here we can see residual and persistent ST elevation in the ECG with deep Q waves. So this is usually seen in patients with previous massive MI associated with extensive myocardial damage and paradoxical movement of the left ventricle during systole. The fifth differential is Brugada syndrome. So this is an inherited channelopathy affecting the sodium channels of the heart. The ECG changes are ST elevation with partial right bundle branch block in V1 and V2 with a coved morphology. So this is called the Brugada sign. Number 6 we have Takotsubo cardiomyopathy. This produces ischemic chest pain, ECG changes with or without elevated cardiac enzymes. This typically occurs in the context of severe emotional distress, otherwise called broken heart syndrome. Number 7, benign early repolarization. It is a normal variant commonly seen in young patients. In ECG, we can see slight concave ST elevation in the precordial and inferior leads with a notching at the J point. So this is called a fishhook pattern. These ST changes may be prominent if the patient has slower heart rate and disappears in the presence of tachycardia. Number 8, left ventricular hypertrophy. This happens because of the repolarization abnormality. In ECG, we can see the left axis deviation along with deep S waves and ST elevation in V1 to V3, ST depression and T wave inversion in the lateral leads V5 and V6. Apart from these differentials, there are also some other causes for ST elevation in the ECG. They are left bundle branch block, ventricular paced rhythm with pacing wire in the right ventricle, acute aortic dissection. This classically causes inferior wall changes due to right coronary artery dissection, pulmonary embolism, acute carpulmonale, J waves or Osborn waves due to hypothermia or hypercalcemia. Thanks for watching. Subscribe for more contents like this.